Good morning, happy holidays, and welcome to the Outcomes Research Seminar and the third in our Outcomes Research Health Equity plus Implementation Science series. Today, we're honored to be joined by Karyn's Bolden, Stovall and Patrick Corrigan from the Illinois Institute of Technology, and they will be presenting their work on community-based participatory research and lessons learned from Peer Health Navigators. We will also be joined by an expert panel, including Dr. Rachel Boutte from Rush University, Department of Family Medicine, and Elliot Morris, who is a community navigator with the Institute for Translational Science and the Illinois Institute of Technology. I'd like to introduce my partner for the seminar, Rachel Brewington, who is our administrative assistant. And my name is Sean David. I am a vice chair for research in the Department of Family Medicine at North Shore and program director for translational science and outcomes research. I also serve as the site lead for the Institute for Translational Medicine, along with Pat Corrigan and others from other 6 institutions. I wanted to just kind of go over some background about the Outcomes Research Network, which was developed at North Shore by key academic and leadership. And it was intended to support, catalyze research across North Shore, but also across our Institute for Translational Medicine academic communities. The goals are to enable community access to effective, efficient, equitable care, enrich the practice of medicine for all, and then support key clinical quality and operational decision-making to maximize health outcomes for our patient and our communities. Our objectives here for the Outcomes Research Seminar Series are to disseminate research that advances the implementation of health equity in our health systems, health equity in our community, policy change to promote equitable care and outcomes, and that advances translational science. We want to support flourishing clinical investigators at every level of the research enterprise. And we also want to continue to cultivate a culture of collaboration and team science. Bridging researchers together across their peer community, across Chicagoland, and we hope into the community with lived experience experts and bidirectional learning, co-creation, and community partnerships. So we ultimately want to deliver on outcomes research that improves patient outcomes equitably and for our communities. So I'm going to pass this on to Rachel, who's going to go over the Zoom logistics and the continuing medical education. Rachel?
Thank you very much, Dr. David. Hello, everybody. The CME credit is being provided for attending today's seminar. To mark your attendance and claim your CME, please text the SMS code to the number listed on the screen. The University of Chicago Pritzker School of Medicine designates this live activity for a maximum of 1.5 AMA PRA Category 1 credits. Physicians should claim only the credit that corresponds with the extent of their participation in the activity. Other healthcare professionals will receive a certificate of participation. The opportunity to claim credit will open at the start of today's seminar and will close after 30 days. Credit cannot be retroactively granted beyond a 30-day period. Therefore, it is important you text in promptly after the seminar to successfully claim your credit. The CMI flyer is attached to today's calendar email and will also be emailed to you along with more instructions on how to retrieve your CME credit after the seminar. In today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on the screen. If you are on a computer, you can access this icon by hovering your mouse over the bottom of your screen. Please give special attention to the audience of your message before you submit it. As you can see on the image to the right, excuse me, you can choose to message either the panelists and speakers, this will include myself, or you can choose to message everyone on the webinar. Feel free to leave your questions and comments at any point during the presentation. If you're experiencing any technical difficulties, please let me know by messaging all panelists and I will assist you as best I can. Okay, I'm going to hand it back over to Dr. David, who will go over our agenda for the day.
Thank you, Rachel. And as with every seminar, we want to make sure to thank everyone working on the front lines in the clinic and in the community in the quest for health equity. and as well as our North Shore leadership and our Outcomes Research Director, Dr. Susan Fisher, for sponsoring this event. Following the introduction today, we'll have our presentation, which will run until 11:15 or so. During that time, we encourage participants to enter their questions into the comments box, as Rachel had mentioned. And Rachel will then make sure that those are delivered to the speakers at the end for a Q&A session. Following the Q&A session, we'll have our Incubator Hub expert panel discussion. That will run for more than half an hour, and it will also include Dr. Pate and Elliot Morris, as well as our esteemed speakers. Following that, we'll have some closing remarks, and Rachel will go over, review the CME process again, as well as we want to hear from you for comments to evaluate this. And then we will be uploading the seminar onto our YouTube channel, along with the other seminars. So for others who were unable to join live today. So without further ado, I'm really honored to introduce our two speakers. Karyn Bolden Stovall is a Community Research and Training Director, the Community Research and Training Director for the Illinois Institute of Technology. And Dr. Patrick Corrigan is Distinguished Professor of Psychology and core faculty member in the Division of Counseling and Rehabilitation Science, the Illinois Institute of Technology. What they have built at IIT has been phenomenal. And I believe Dr. Corrigan used to work at North Shore ages ago. So welcome back. And I'd like to introduce both of you and thank you for your presentation today.
Good morning, everyone, and thank you so much, Sean and Rachel, for the warm introduction. I'm going to go ahead and share my screen, and then we'll go ahead and jump right into the presentation. All right, so hopefully everyone can see my screen. Today we're going to talk specifically about community-based participatory research and lessons learned from our Peer Health Navigator studies. I'm Karyn Bolden Stovall. I work at IIT. I am one of the people on the team who is a peer, which means I have lived experience with anxiety and depression. What we're going to talk about specifically today is what community-based research looks like, what we hope that we can kind of help to create, and eliminating the healthcare disparities that we see not only across Chicago, but across the country. So today we're going to specifically talk about introduction to community-based participatory research, what that looks like, the ideals, the goals, the model. We're going to talk about our inspiring change model that we utilize primarily at IIT. And then I'm going to go ahead and hand it over to Pat, who's going to talk about lessons learned from Peer Health Navigators and the potential for CBPR for healthcare research. So one of the things that I like to do when I am talking about CBPR or community-based participatory research is the fundamentals of it and what that looks like. And one of the quotes that I think really does a great service to that is, "The way to right wrongs is to turn the light of truth upon them," which is a very famous Ida B. Wells Barnett quote. For those of you who may not know her, she was a very famous journalist in the 1800s that talked about work against lynchings that were happening all across the South in the United States. And I think this is a beautiful quote to kind of get us started, because it really talks about eliminating wrongs that are perpetuated in our healthcare research system. And so I want to get us started with what community-based participatory research is. And essentially what it is that it's a collaborative research process in which traditional research teams work in conjunction with community members to utilize the strengths of each in carrying out research that are designed for the benefit of all the community members. Okay, CBPR is also known as Community Partnered Participatory Research, or CPPR, Participatory Action Research, or PAR, or Community Engaged Research. So we will sometimes use those terms interchangeably, but we're all talking about community-based participatory research process. So CBPR is really designed to address equity, specifically within the healthcare research and healthcare system. The purpose is to be extremely inclusive, to be more inclusive than has traditionally been available to traditional research teams. And it really looks at, the reality is that for hundreds of years, scientific research did not include community members appropriately and did not value the lives of those that they were studying. Okay, this led to, numerous abuses of research participants and to distrust of researchers by community members. We all know about Tuskegee and all of those kinds of studies, and we are really trying to focus on bridging that gap between the academic research community and the communities that we do research studies on, but also really trying to address the equity piece and the disparities that we have going on in healthcare in general. Many of the previous, prior to the 1970s specifically, research projects were using research participants who were primarily from low-income communities, people who had less formal education, also obviously primarily people of color, immigrants, people with disabilities, and LGBTQ plus communities. And so what we want to address in this process is that the burden is now on us as researchers to build a bridge back to these communities and work together to create research that results in real systemic positive changes in healthcare. And with CBPR, or community engaged research, that is our goal. That is what we obviously try to do every single day. The CBPR model is structured so that individuals who are underrepresented or communities that are underrepresented should be involved in the research process to help reduce unfair barriers. All right, so now what we're going to do is we're going to talk specifically about the principles and the benefits of CBPR. One of the many principles is that we recognize community as a unit of identity. Right? We understand that each community has its own identity, has its own understanding, its own history. And it also looks at an ecological perspective, specifically social determinants of health. Looks at things like economic, social, and cultural issues that are really designed to understand how the community participates and uses their healthcare and their healthcare experience to further not only their quality, but their quantity of life as well. It also recognizes that community has strengths and resources. Traditionally, in the traditional research model, we tend to look at deficits. What are the problems that happen in these communities and how we can help eliminate them? But this model also understands and recognizes and values the strengths and relationships and resources that every community has, no matter their limitations. It also facilitates collaborative and equitable partnerships. The CBPR model is based on the fact that the community and researchers, academic researchers, partner together in this process. They all have a voice and they all have say. It also fosters co-learning and capacity building within this process and reflects the community's interests and needs. What we're trying to do with CBPR is move from a top-down structure in which the researchers hold all the power and is more reflective and collaborative with community and addresses the community's needs and wants. So some strengths of the CBPR process is that it's collaborative. It's meant to be an open communication process. It's meant to offer strength, and it shows the importance of the community and the community's strengths. It's designed to eliminate disparities and improve communities' options, choices, and collaborative works with traditional researchers. Now we're going to switch focus a little bit to talk about what we call and at IIT is inspiring change. This is a project that we worked on that really helped us to develop our CBPR model and was created to address healthcare obstacles by involving African Americans with mental illness in all stages of the research process. This was a grant that we got about 10 years ago and has really helped shape what CBPR looks like on our end and all the trainings that we typically do at IIT. So the Inspiring Change CBPR model really focuses on three specific pillars. One is the person with lived experience. So that is the person who has the healthcare condition that is being studied by the research process. They are often typically from a disenfranchised community. It depends on which research project that you're looking at and the type. The academic researcher, so people with PhDs, MDs, and then community advocates and or service providers. These all three specific branches work together to create the CBPR team, which I'll talk about more in a minute, that really creates a holistic view of what's actually going on in the community and how it can be addressed by that specific research project that we're looking at. So I'm going to go a little bit into deeper dive on what a lived experience member is. These are typically people who are, in traditional research, are the research participants, right? They're the ones who are being studied. However, in the CBPR model, they are actual team members. They are people on the team who have or who have had the medical condition which the project studies. When seeking lived experience members for the team, it's also really, really important to consider diversity. And when we talk about diversity, we mean diversity in all areas. Okay, so obviously race and ethnicity are typically the ones that we tend to focus more on as a society, but we also really want researchers to consider things such as immigration status, whether someone's documented or undocumented, gender identity, income level, formal education level, and disability status. Disability status applies to both physical and mental health conditions. It's really important to include diverse groups of people who are reflective of the populations the study's intervention works with, which can make sure that to foster greater inclusivity and provide real world solutions. One of the things that I love about the CBPR model is that it's really designed to not only help create and facilitate a research study at the beginning, but throughout the entire process, so that once we have a solution or an end objective, that's something that will be applicable to real world conditions. Also, our model for CBPR is really focused on recovery. You know, we are located in a psychology department. And so what we mean by recovery is we mean that people who have the health condition do have long-term hope and systems in place to make sure that they maintain recovery, whether that's from mental health, a substance use, or physical health condition, and really focused on them as people who have control of their lives, who have agency, and can have empowerment and hope. The CBPR model is structured and rooted specifically in diversity and equity and inclusion, or DEI. It's really important to note that unlike the traditional research model, all participants in this project share power equally, okay? They all work together on the research from its inception until its conclusion. Typically, research teams are put together at the beginning of the research project or process and stay together through the entirety of the project, okay? That depends on which project you're looking at. Usually projects are anywhere from 1 to 5 years typically, but they all work together as a team collectively. In addition to that, when we mean power sharing and equality and equity, we also mean that any research papers, presentations, projects, everyone is listed as a co-researcher, even those who are non-traditional academic researchers, and encourages the use of community members as primary speakers and spokespeople for the project. So the logistics of a CBPR team, you know, what does it actually look like when we're on the ground and getting ready to run one, right? CBPR teams, like most research, require time for the startup process. You know, when you're doing a CBPR team, it does tend to slow things down a bit. Usually it takes a little bit longer to get things off the ground. But the benefit of that, though, is that once you have the project running and everything's going, you are pretty confident that you will have the necessary expertise and experience on the team to help get you through those challenging times, you know, help you get through the recruiting process. CBPR teams usually meet initially once a week, once the design of the project is getting started, and work together to implement it given the project's needs and requirements. Okay. Ideally, a CBPR team consists of 6 to 10 people who will remain on the team for the duration of the project. And there's a leadership team within this. Okay, so the leadership team is comprised of 3 people, at least 1 academic researcher, 1 lived experience member, and 1 service provider member. One of the things I do like to talk about in terms of CBPR is that, yes, there is at least 1 lived experience member, but ideally at least 2 to 3 are on that team of 10, so that there is the ability for people to bring in all different types of experience and understanding and expertise. Another key component of the CBPR teams is that all members of the team are compensated for their time. We recognize that people with lived experience and community members have their own knowledge and expertise that they bring to this team, and so therefore they should be paid accordingly. So all of our CBPR teams are paid commensurate with their experience. So within the inspiring change model, I want to talk about the 3 different types of research that can be looked at with a CBPR team. Typically, it's understanding a problem. So research question example could be, why is emergency room use so high? And one of the things that in this particular type of model that people look at is, perhaps doing a survey to ask people those who are in the emergency room, why they're using it, what could be a better use of their time. Another aspect is designing a solution. How do we help people, or how do we help that nurse line get better, right? The survey method. And then testing a solution. How do we make sure that the nurse line is as effective for helping people avoid emergency room visits? As most of us know, emergency use time is very valuable, right? It's a lot of triage. And sometimes people use the emergency room that could probably be better use of time going somewhere else, right? So testing a solution would be looking at measuring changes in emergency room visit after a helpline has started. This is just a piece of our instructor manual from the Inspiring Change Leadership Training. And these are some photos of what it looks like on the ground when we have an in-person meeting. I know because of the pandemic, a lot of us are used to very virtual meetings, and we still do have mostly virtual meetings, but we also do a lot of hybrid. And so this is what an in-person meeting looks like for us. Leadership topics and training, those who are on the leadership team and the CBPR Inspiring Change model do get together and meet independently from the regular team to make sure that they're all on the same page. We do trainings that talk about, introduction to research and what CBPR is, leadership styles, communication. How do you manage a project and lead a project and research process in which there are many people on the team who may not have the academic or medical background that the primary investigator has. We also talk about professionalism, mentorship, and problem solving together and conflict resolution, right? One of the things I'm asked all the time when I'm in the community and providing trainings to community members is, well, what does this look like when we disagree? And I like to tell people that one of the things that CBPR does is that it's an equalizing force, and that there are going to be disagreements like on any team. But one of the things that we want to help do is figure out how do we do that in a way that is collaborative, in a way that is allowing us to really advance our objectives to eliminating this healthcare disparity. So just final reflections on what CBPR is. And one of the most important aspects of CBPR, obviously, is to include a variety of stakeholders, right? Academic researchers, community members, and service providers work together in conjunction to provide a holistic view of how this research project can really work and be implemented in a way that's successful to try to ensure that an intervention is successful in the real world, okay? It's imperative to treat each member on the team equally and with respect everyone's opinions, and leadership's job is to ensure a healthy and functioning team. Obviously, CBP at its core addresses the lack of diversity in research and encourages and promotes relationships between researchers and the community for the benefit of all. And with that, I'm going to go ahead and stop the share and turn it over to Pat, who's going to talk to us about Peer Health Navigators.
So thank you, Karyn. You should be able to see this. Yes. Yes. Okay. Great. Thank you. And thank you, Sean and Rachel, for having us. This is a great opportunity. What I wanted to do is use our research that's supported over the past decade by I don't think I have the slide show up.
would you like for me to
No,
take over? No.
you got it, right? Lessons learned from Peer Health Navigators.
Right there. It's
All
there.
right. So over the last decade, we at IIT have been doing work on Peer Health Navigators, as Karyn sort of insinuated. Our work is more on the mental health side. And so one of the issues people have discovered over the last several years is that people with serious mental illness get sick and die 10 to 30 years younger than everybody else, affecting almost every organ system in the body. As a matter of fact, about a year or two ago, I edited a book through American Psychiatric Association Press looking at health and wellness in people with serious mental illness. And I wrote it with Sonia Valentine. I met Sonia on a CBPR project about 10 years ago. A person with lived experience who also had been homeless, had been in jail, was getting her life back together again. So she was an ideal partner for what I did. And as we found as it went, that COVID equally was overrepresented in people with serious mental illness and a challenge to be looked at. The problem with this high rate of morbidity and mortality is that inpatient rates for people with serious mental illness, not due to their mental illness, but due to physical illness, goes through the roofs and leads to unnecessary use of nursing homes and other institutions and greater use of emergency rooms. And it exacerbates their disability itself. It makes their mental illness worse. And so we're kind of wondering why. Why is it people with serious mental illness have such a high rate of morbidity and mortality? Part of it, we might say, is the disease side. There is some evidence at this point, somewhat limited, of a genetic comorbidity, that whatever the genes are that lead to a serious mental illness, like schizophrenia, for example, might also lead to heart disease. There's also some evidence of allostatic load, just the stress of having a serious mental illness for a long period of time, what it does to your physical health, and also the unintended side effects of treatment. But what becomes clear, and what's a resounding theme of what we're all looking at, is how social determinants have an equally, if not bigger, effect here. Part of social determinants can be looked at in terms of diversity, equity, and inclusion. We frequently start looking at that in terms of ethnicity, but then we realize DEI is such a rich concept in terms of a gender identity, sexual orientation, age. And separate from that is social disadvantage that's experienced by many DEI groups. We are quite clear that being Black does not mean you're poor or in jail, but unfortunately statistics suggest it's a much higher rate. And so this co-poverty, co-criminal justice involvement drags down one's health even more. And the problem, therefore, is what we've heard over and over again, is a fragmented and under-resourced service system that's not culturally competent. Let me put an image to the service system. This is the city we're at in Chicago. If you're of low income or no income and you had a respiratory problem, you go to Cook County Hospital on the near west side. And then maybe uptown, you found a podiatrist who'll see you on Medicaid or for free. And over there is also an optometrist out by O'Hare. And the dentist is in the near north side. And by the way, I live on the south side where my mental health provider is and my pharmacist. On top of that, if I'm a veteran, and we realize there's a series of veteran facilities around, Jesse Brown, which is close to Cook County Hospital, and Hines, which is out in Maywood, and what was called North Chicago VA is now Levels up by the state line. And then there's all these CBOCs out there. And there's a relative mishigosh of places you can go to get care. This represents first the fact that many services are unavailable. There's just not the bricks and mortars or insurance coverage to cover them. And second, what is available is not accessible. That we know traveling in Chicago can be a relatively nightmare. And by the way, this is an urban focus, which we're strong on that. Add rural, and accessibility becomes even more compounded. On top of that, we're more and more realizing that the status quo healthcare system probably represents the white Western view of things. And so there's more and more concern of cultural relevance. There was an idea of competence. This is now being replaced with the idea of humility. that people from one culture need to be humble in terms of working with people in another culture and helping that group reach their goals. And so what led our research is the fundamental equation that engagement leads to health. Even if it's not great engagement, there are healthcare providers out there which people can be hooked up with. Now, for us, engagement does not mean adherence. In the mental health side, there's always this idea if you just took your meds, everything would be fine. We're not saying that. We're saying that instead, engagement means that people determine for themselves what interactions they want and keeps them over time. Also, health for us is a lot broader than just sickness. It's also prevention and wellness. And so we're interested in what are the barriers to engagement in health. And we see three. One is where, or at, fundamentally the fact that things are not there, they're unavailable, inaccessible, or payers are lacking. Two is providers, whom too few providers are DEI providers and they lack cultural, again, humility. And three is interventions is what? What is the intervention you're doing? One thing we became interested in is this idea of peer health, of peer navigators. This actually emerged out of the much broader field we know of community health workers. Community health workers are people, professionals, paraprofessionals who are helping an individual with their health goals, driven by primary care, but clearly open to and moving into specialty care, dental care, podiatry, eye care. It all occurs in the person's community. So one of the big jobs of community health workers is to promote transportation so that the patient can make it to the setting, get educated about what their options are, provide advocacy if nearby. And so everything's in the community. So community health workers are out there walking people around. And it represents their community culture. Again, we tend to first think about this in terms of ethnicity, but we realize that culture also can represent gender identity, sexual orientation, and the like. Community health navigators morphed into patient navigators. And patient navigators comes out of the breast cancer community when about 30 years ago, people realized that a diagnosis of breast cancer opened up a maze of possible options. And so the navigator literally practically walks them around the healthcare system. Now think about this, in a big system like North Shore, that's pretty daunting about all the different places you have to go in North Shore. Think about it for people with low income. We're not limited to North Shore. They have to get all over the metropolitan area. Peer navigators came from patient navigators. Peers is a big insight in the mental health community now. Peer support originally comes out of mutual support groups where people with lived experience of mental health challenges get together, share ideas, provide support, help people move forward. And it morphed into peers not just being in support groups, but them being paraprofessionals themselves. Them being people who are hired by a healthcare system to help other people with mental health. In terms of navigators, is to help them walk around the system. Who is a peer navigator? It's actually two. One is it's a person with lived experience of serious mental illness. If you're not familiar with this, you might say, how can a person with schizophrenia ever provide this sort of service? Research is quite clear that recovery in serious mental illness is a lot more optimistic than people thought. And these are people who, with ongoing support of their own, ongoing psychiatrists and counselors and supporters of their own, they get hired to help other folks. The other thing about peer is they tend to come from the same community. So if we're doing a project on peer navigators amongst African Americans, we will hire Black people who are in recovery from mental illness. We've done 4 funded projects on this over the last decade, and I wanted to share with you findings from a couple of them and make sure we have enough time at the end for discussion amongst us. The first one we did, which started about 12 years ago, is looking at health and wellness needs of African Americans with serious mental illness who are homeless. We did this in Edgewater, Uptown, and this was the CBPR team. You can see I'm in the middle with a couple other of the investigators. The big gentleman to my right, African American gentleman, was actually a provider. He was a service provider. and everybody else, there were people with lived experience. When I'd met them, all of them had been homeless in the last year. All of them had ongoing serious mental illness. All of them are experts on what it took to help someone with mental illness in the world get hooked up with their healthcare. And so we did the very practical task of coming up with a manual, coming up with worksheets so we could hire Peer Health Navigators so they could go out and help other people engage in healthcare services. Let me talk to you about the practical aspect of this that Karyn alluded to. I've been writing grants for several years now, and let me tell you, I could write this manual in 2 days. But the nature of CBPR is I am not from their community. Not only that, I only represent one view. I don't represent a consensus view. And so this is a very time intensive, took about 9 months to meet with them to come up with a manual, get outside feedback from other people who lived experience and go with it. The manual includes a summary of what Peer Navigators do, what are helping skills they use, and what resources they might. There's essentially two aspects to peerness. One is support itself. And I think support is both interpersonal and instrumental. Interpersonal is an emotional, I'm there with you kind of person. Instrumental is, and I'm going to help you achieve what you want to achieve. Peers do this differently than, for example, I would as a clinical psychologist. They do it by disclosing their lived experience. Hey, I've been there. This is what I learned. And like any provider, they have to balance dual roles that they have to disclose, they have to make sure it's there to help the client, not to help themselves. And so we did a couple studies on Peer Health Navigators for homeless people. These are some of the findings. In a mediated model, what we believe the most immediate effect of Peer Health Navigation is increasing engagement in available services. And so the dashed line are people that are randomized to the Peer Navigator group, the dotted line to the control group, which was treatment as usual. We actually every month contacted them and had a comprehensive interview on what kind of appointments they had. And you can see that appointments steadily went up after the engagement phase. In the Peer Navigator group, it went up quite significantly and maintained over time, whereas any bump that happened in the treatment as usual group tended to go down over time. That's appointments. Do they get appointments? This is achieved. Did they make the appointments? Similarly, still up. Again, let's remind you what this is. We actually went and hired 3 Peer Health Navigators through thresholds. And these were people, I'm getting my studies mixed. We hired 3 Peer Navigators through Heartland Alliance. These are people with lived experience who would pick the client up at their home, or if they're on the streets, and take them to the county hospital and get them to the appointment and take them to the labs and take them to their meds and follow up. Now, a separate study, we were interested in what kind of impact it had. In particular, there's a study on 66 people randomized to condition with 1 year of services. We used the SF-36 to look at the degree to which people in the intervention group versus the control group reported better physical and mental health status. This is a reverse keyed measure, so going down is good. And so as you can see, a significant interaction for people in the treatment group versus control group and their perceived physical and mental health status. Significantly better on the SF-36 increase in their perceived and mental health overview. And finally, significant benefit in the idea of recovery and quality of life. So that study was funded by the National Institute of Minority Health and Health Disparities. We separately went to a study funded by PCORI. This was the CBPR team on that. This was on Latinx. This was done in the Pilsen area. The goal was to adapt the Peer Health Navigator program for Latinx people with serious mental illness living in that area. These are our partners. These are all people with lived experience, including this, plus the scientist and the treatment provider. In this case, we started with a manual. We had to redo it significantly to meet the Latino agenda. Let's be clear first, this is always a lot more than just doing language. As a matter of fact, the team decided while the manual is in English, the worksheets are in Spanish, so that the service recipients could get the manual in whatever language is most convenient for them. Also, in doing work with them, a priority, the two big things that came up that were different with the earlier study with African Americans was one was immigration. The idea that they were very cautious about getting involved in government sort of things because of immigration issues, even if they were citizens or here legally. And two is the role the community has, especially the Catholic Church, in their care. We did a third study about 5 years ago. It started just before the pandemic. The question is, we know people with serious mental illness, like a lot of people, have bad health care problems because of diet and exercise concerns. And so we wanted to adjust a standard diet and exercise program for African Americans. That program was adjusted for those people's symptoms, cognitive disability, interpersonal challenge. What we wanted to do is add peer navigators to that. So again, everybody has a hard time if they're not already doing well in the diet and exercise space. Peer Health Navigators were to help meet the person, tell them where they can get the food, help them cook the food. Exercise, actually, we were concerned about what we call exercise deserts. One of the secrets to doing activities is to try to put it in your daily regimen, walking around and the like. And if you live in some part of the city, this idea of walking around becomes a lot riskier. And so we, as ITM 3.0 is launched in the last 2 years or so, we have joined it to anchor the community-based participatory research arm of ITM. And what I want to share with you is a training and grant opportunity that's available to North Shore and any other ITM folks listening in today. It's Inspiring Change Training. The last round we did is from June to September of last year. We have training for inspiring change for community leaders, CLs. We trained 32 community leaders. We paid the community leaders. Community leaders are people of color from with lived experience. If you're a community leader and you want to get involved, we'll share with you how to do that. We also trained ITM investigators. They are there as service matter experts, and we trained 25 of them. The goal then was to match, to get community leaders who, for example, had interest in long COVID and are Black, get together with investigators who do long COVID. And we matched them up. We had joint training, and then we received submissions. There's a grant submission, the grant competition for 30,000. Oops, this is direct, not indirect. 30,000 direct. So you can apply for a grant through ITM, and we'll share with you in a minute when the next round is coming up. Receive $30,000 direct. In the first round, we received 6 applications. Applications included a study on long COVID in the Black community out of Advocate, a study on allergic rhinitis amongst Black people out of Rush, a study on multiple sclerosis and Medicaid out of Rush, a study on trauma and hypertension out of Illinois Tech, a study on musculoskeletal pain among Black people and related physical health education out of Rush, and a study on exploring access to mental health care. And we funded 3 of these, and 3 of them are now in the field. So the next round of Inspiring Change training is coming up. I believe Sean has the flyer, which we're going to share with you. Some things to keep in mind is we're asking you to contact us soon, because in December, we're going to have a training for community leaders and for ITM investigators to learn this, to put together a proposal, to propose it. We will announce awardees May 1st, and the funds will start July 1st. Here's something we learned after the first meeting, after the first round we did this. Our intent that's consistent with health equity research is for community leaders to lead the agenda. It's important for them to tell us that they want to work on in their community, they want to work on COVID or food insecurity or breast cancer. The rate limiting step we didn't foresee is we have to have investigators or subject matter experts in that area. So if the group wants to work in long COVID, the subject matter expert has to have some background in long COVID to do it. And so it brings the challenge of how going forward do we ensure priorities that reflect the community. How do we get community leaders in there to make sure what rises to the top is what they perceive to be important things in their community? And how do we match them up with investigators from ITM, those of you who are investigators, to join in on this? This is targeting early investigators, but we're very open to how we define early. So let me stop here and turn it back to Sean.
Thank you very much, Pat and Karyn, for a really inspiring presentation. We have collected some questions that Rachel is going to
Okay, thank you, everybody. Yes, we have some questions here. First question is from Susan Fisher. While peer navigators assist community residents with many of the SDOH CBPR is typically focused on a specific topic. Even following input from community advocates interested in a particular health problem, the actual masses in the community at times do not welcome the research efforts. For example, they are not interested in replacing McDonald's with a fresh produce market. As researchers with specific expertise, aren't we typically still going into a community with a topic plan? This seems to be an unsolvable struggle between academia and community.
So I'll go first, Pat, if it's cool. And then I saw the second question. And Rachel, if it's okay, I would prefer to answer the second question first,
Sure.
and then we can go into the larger question. So the second question was regarding payment for CBPR team members who are the lived experience members. And so for those, typically we recommend paying anywhere between $20 and $25 an hour for their time. So the way that many of our projects are run is we have 90-minute meetings. And so participants are paid for an hour and a half times $20 or $25, whichever one it is. We typically pay $25 an hour. And then if they're being asked to do anything in addition to that, we also pay them for that time as well. So $20 to $25 an hour is typical. And Pat, please correct me if I'm wrong, if you want to add anything there. And then the first question with regards to interactions with community members. I think it's definitely challenging for sure. And I am someone who is both a community member and an academic researcher. So I kind of walk both sides of the line. I think a couple of things that, yes, traditionally researchers do have expertise in one particular area, and that you do go into the community kind of focusing on what it is that specific issue is. But I think one of the many reasons why communities in general fear research and don't want to participate is because of the horrific history. Tuskegee wasn't that long ago. I know it technically ended in the 70s, but there's still a very much cultural understanding of what research has done to people of color, specifically people who have been disenfranchised. And part of that work that we as researchers have to do is we have to reestablish that trust, right? We have to really go in being prepared to listen, owning that history, acknowledging it and being upfront about it, but also acknowledging that there's still a very real divide there. We saw it very clearly in the COVID response, right? With people refusing to take part in the studies for COVID and with people being so afraid of what the COVID vaccines would do. And a lot of that has to do with trust, and that's not something that's mitigated overnight. That's just reality. It's not. It's going to take a lot of work and a lot of time. And I think with CBPR, every day we take one step at reestablishing that communication, reestablishing that bridge. And with regards to the example, you know, for communities who've been disenfranchised, you know, they live in food deserts and food swamps. You know, I used to live in Chatham. I still live on the south side of Chicago, and the reality is you get accustomed to things. You know, I love McDonald's just as much as the next person, right? So I think we need to kind of move from an either or strategy to be something that's more inclusive. And I think that's kind of how we really do address that issue. And then Pat, I'll turn it over to you to answer.
Thank you, Susan. I'll be honest, when I go into a group, I do have an agenda. But I also, be honest, really, I just don't know at all what it takes to live in certain parts of the city and have low income and be homeless and do this. And so the CBPR team is a partnership. And I can't tell you the number of times they've told me that's just dumb and we won't do it. So that what we end up with is wholly owned by them. And in terms of the specific issue, in terms of McDonald's, again, as a naive guy, yeah, like, let's just stop eating McDonald's. We've really gravitated with lots of people more to a harm reduction issue for dealing with fast food. We gave it the word harm reduction, but our community partners are the person who crafted it for us.
Thank you so much. Thank you very much. I don't believe we have any more questions right now in the chat. Please feel free to keep posting your questions if you think of anything later, and we'll make sure to get these to our speakers.
I do have one question. Also, I found my audio button. Hold on a second here. I just want to thank you both, Karyn and Pat, for a really inspiring presentation. So to Karyn, the inspiring change research types, there's 3 types that you mentioned, right? Understanding the problem, designing, and testing. Do you have examples where you've combined the 3 into one project so that in many ways it might be analogous or homologous to implementation science, where there's the design end and then there's an implementation adoption end? Can you comment on the overlap with implementation science and how you, because we're trying to take that approach and we need to learn from the pros and how to do it right.
Yeah, I can talk a little bit about that and then I'll turn it over to Pat. I don't think specifically in one specific funded research project we've done all 3. What we typically will do is a step-by-step. So we'll take one project from understanding the problem and then go through to designing and testing. That tends to work really, really well. Simply just because, you know, there are a lot of steps in each of those processes, right? And what you really want to do is, and that's one of the reasons why we are so happy to be able to do pilot funding through the ITM, is that we are able to kind of help people get to that process. Typically in research, especially larger scale research, you know, they're really trying to test a solution, right? Like we want to get to the testing, and then there's not a whole lot of funding necessarily for understanding the project, the problem. So we typically do them one phase at a time, and we do them with a CBPR team, and those are usually 1 to 3 years, and really trying to figure out step by step issues. And I think it's really important to take that time with each of those processes. I know, especially with CBPR teams, it does take a little bit longer, and we try to get to a solution as quickly as possible. But I would like to caution us with that. You know, just because we have a solution doesn't mean it's the right solution, you know? And I think that's a really important thing for us to acknowledge, that, you know, I know we're all tied to grant funding and we all have deadlines, and, you know, we all like to publish our papers so that we look good in academia, and that's super important. But understanding the nuances of each of those is really important. And I think, a big part of that is taking it step by step through the process. And I think from our perspective, at least, the Peer Health Navigators is kind of like a culmination of that, right? That's the ultimate, you know, testing the solution. And what we've seen so far has been, you know, it's been 10 years basically, right, since we started this process. And we see continually over and over, we currently have 2 Peer Health Navigator projects running, that because we've taken the time and because we've spent put in the work and the equity and all that we need to do, that we're seeing the fruition of that. And it's giving us data that shows that, yes, this is a real solution, especially in a city like Chicago that is very much racially segregated, still very much racially divided, in terms of you can literally almost draw lines around the city and say which race and or ethnic group lives there, and really showing us that. And with that, I kind of want to turn it over to Pat so he can talk a little bit more about that as well. Thank you.
Thank you. Yeah.
So the way I heard the question, Sean, is we sort of broken it up into what's the problem, is there a solution, test the problem, test the solution. And CBPR itself at the end of the day is grounded in research, which is what we're speaking to today as a group of researchers. So we're looking for a discrete research project you can do. We are by no means saying everybody needs to start with describe the problem, come up with a solution, test the solution. You go right ahead to testing the solution. About implementation science, let me back up a minute. I have to admit, I find one of the interesting things about being in the Institute for Translational Medicine is, to remind everybody, translational medicine is from bench to bedside. And we haven't figured out yet, and would love to engage in people on whether you can do translational medicine at the bench side of this continuum, because we tend to have a public health focus of what's going to work in the real world, especially when you look in diversity. And so I think beginning with that makes it more implementationable. Is that a word? Makes it more likely to be implemented.
Mm-hmm.
The issue about implementation, as you know, as your group knows, it becomes ungodly more complex when you go at it. The good news is we come out of this at least starting with the idea that is the community going to be open to it. So it's not like something has come up in a college campus and now we're trying to see how it works on the west side. But then implementation probably to me might be an additional CBPR project. So we have a grant that just went in on food security. On doing Peer Health Navigators for food security. And part of that, the implementation is a scalability question. And the good news, by the way, on mental health peer navigators is CMS now allows certified people in Illinois that are peer navigators to bill. So it becomes a more scalable intervention.
So thank you. So really, we're not talking about two parallel processes that are independent of each other, but rather there's a lot of CBR work that needs to be done before we even begin to talk about implementation, because we need to know not just the solution, but also test it and make sure we have the right solution for the community.
My sense of NIH, though, is they're looking for implementation. They're looking for hints of implementation anywhere along the line. So even when you're first doing something, we first launched Peer Health Navigators and did a qualitative arm to it to ask service recipients about what worked and what didn't work and how to make it better. And that's sort of the 5 hybrid models. That's sort of one way to get at implementation issues when you launch a new project.
Great. Well, thank you so much. So I think, Rachel, we can advance to the introducing the panel. So again, thank you for a brilliant presentation. We're honored to welcome our 2 expert panelists, Dr. Rachel Boutte, who is an assistant professor in Department of Family and Preventive Medicine at Rush University, and Elliot Morris, who is Community Research Navigator with the Illinois Institute of Technology and the Institute for Translational Medicine. So welcome to both of you. We'd like to start off with introducing, based on this presentation today, how we can implement results from this research to first advance health equity in our health systems. And we open that up to the panel to get your thoughts on how we can implement some of this work with community health navigators who are peer navigators in our health system, places like Rush or University of Chicago, North Shore. What are your reflections on that idea, Dr. Boutte?
Great talk, Karyn and Pat. It's so wonderful to hear more about the work that y'all are doing. I think that within our health system, there are so many levels of breakdown as it relates particularly to equity. And so the model that was presented of using peer support, peers as providers, kind of having this navigator role, we could really think about re-envisioning almost any segment of the health system taking an approach like that, just because of the complexity of doing even the simplest task in healthcare, such as following up after a visit. I'm working on a project right now where we're thinking about how do we equip a patient for the medical encounter? Like, what does it mean to go into a medical visit with the provider and actually know which questions to ask, actually have an idea of the agenda, what questions will be asked of me, how can I be prepared, actually give the provider the kind of information that they need to make an appropriate referral, things like that. And so I think that is a perfect place, just as an example, where having someone there with you, whether it was during the appointment or even just before, to kind of talk through, hey, this is what's going to go on, here's how to be prepared, here's what to bring with you. And then at the end of the visit, this complex system of referrals and follow-up visits and appointment scheduling. So I think that kind of model could be really, really effective just at the level of the appointment and the follow-up.
That's exciting. And so health system leaders must be paying attention to that, because they like to value-based care test everything. And right, but do you think that that's going to be something that's going to be supported by payers? And
yeah, I think you have to show, right? The bottom line. So it's, for me, like, this work is a deviation from a lot of what I've done before. It's been more individual kind of behavioral interventions, but I've been thinking a lot more about the bottom line side of things. And yeah, implementation science, if you want this to be scalable, it has to make sense. The money has to make sense. And you have to demonstrate that through your work. So I think that the existing literature on some of these topics show that, yeah, the potential is there when people understand how to make the most out of their medical visit, when they understand how to make it to those follow-up appointments, they will have better health outcomes. That will mean fewer visits to the ED. That will mean all kinds of positive outcomes for the healthcare system from a financial standpoint. But we have to show it. And I think we need enough data to be able to demonstrate something like that.
absolutely. Elliot, what are your thoughts about this?
Excuse me. Thank you, Sean. And thank you, Pat and Karyn. Great information. It's my privilege to work with both of you. Rachel pretty much said everything I was thinking about, but yeah, it does need to change from the beginning in almost every part of the health system. One is getting people there. There are so many times when people's appointments are all over the city of Chicago. And as Pat said, and I think Karyn also said earlier, a lot of people have problems with transportation, accessibility. And if you're telling me to go from point A to point B, that may be difficult. So I know there are health systems that are very helpful with getting people, they pick up people and take them to their appointments, which is great. But also, once the patient gets there, make the most of that 15 minutes. You know, and make sure that the patient knows that you're there to help them, and not that you're there to tell them what's wrong. A lot of times people, especially in our Black community, we feel that, you know, we go to the doctors and we're not getting the information that we need. We're not being heard. And listen to the patients. You know, it's an opportunity for you to listen to the patients. I understand the time constraints, and I understand the time that the doctors and physicians and the clinical staff have to work with patients, but we also have to understand that the patient is there not knowing medical jargon. So you really need to kind of be there to talk with them. And that's why I feel navigators are so key, because they are there to actually be someone to maybe help make that bridge. Also, maybe help them write down things. You know, in my personal experience, being someone with lived experience, I have to write down stuff when I go to the doctor. before I go there, I make sure I write it down, because often when I get to the doctor, everything I think that's going on that I want to say, I forget. And by the time I remember it, I'm on my way home. So actually making that full, like I said, just a full rehab, a revamping of the system, little by little, I think will make a change. But the first change we need to make is actually just trying to get the systems that we have across the board and not just in one particular area.
Mm-hmm. Yeah, I mean, the healthcare journey, when, say, certain places don't accept Medicaid, so people need to go to the UIC or Cook County, but then all their other care is in the South Side, and then there's a lot, it's not only appraisal support, but it's also, it's how does one integrate all this together and show up at the right place at the right time and still get all the follow-up? Do you think it's almost like I could imagine a full-time job, that having someone check in every day, health coach, could make a big difference, especially if it means you have to mobilize to go across town. It's not trivial to do that. So that sounds like
full-time job. So
Yeah,
Karyn can help me out, but I think we have 3 Peer Health Navigators working full-time to serve 15 people, 12 people.
They're currently serving 25, I believe.
Really? Wow. Okay.
Is that a ratio that's reasonable, or it sounds like a lot of
11:35 a.m. 11:35 a.m.
my
So
Siri.
it's reasonable. I think because the Peer Health Navigators that we have on one of the teams, we have 2 separate teams. The one that handles about 30 or 25 or so people. The goal is to not have more than 10 to 12 per person. And it's also really important to think about where people live. The Peer Health Navigators really do full service, right? So they will go and pick people up and take them to their appointments. They will walk them through the grocery stores to help them make better food choices. They will help them, navigate getting a blood pressure cuff with their insurance. It's a lot of work, they'll call and make those phone calls. And, if you're not using your electronic health records, you can be waiting on the phone for 30 minutes to speak to a person to get an appointment that may later be canceled 2 weeks from now. So it's feasible. It's a lot though. It is a lot of work.
Yeah, thank you. So on that topic, how do we integrate this model into the community in a way that if our health systems are systematically supporting it, we can actually get to where patients where they are, not only in the ivory towers and the bricks and mortar, but in the community? What are some thoughts about, maybe you're doing a lot of this already, going to meet patients at their homes or at community centers, but thoughts from the panel about how we can implement results in the community beyond what's already been done in the research space?
Well, I have a question for Rachel, because I think we're in a serendipitous moment for Peer Health Navigators for mental health. And the serendipitous moment is about 30 states in the union allow agencies like Thresholds to hire people to provide Peer Health Navigators for people with mental health challenges. Who pays for community health workers, Rachel? or how would you do this for breast cancer? Or how would you do this for other health conditions, other settings?
Yeah, it's a good question. I mean, the first thing that comes to mind is just the framing of it, right? You could have the exact same role, doing the same stuff, but just call it by a different name so that it could fit into an existing pay structure. Because I think, that would be the biggest barrier. There are not structural level things that would accommodate physical health conditions, nothing that is uniform across the board. But within different conditions, there are little roles. Like, for example, I've worked with a lot of patients who a family member is a primary caregiver, say in like oncology. And so then the family member will get a certification of some kind that basically allows them to function as a paid caregiver. So essentially they're just getting paid for what they were already doing, which was like driving the patient around and cooking their meals and etc. So they are able to get a certificate or do like a training program that allows them to get paid to do that. So I would imagine that the sort of fastest way of doing this from an implementation standpoint would just be to identify, like within a given sort of category of illness, where are the roles like that and what is required to get people those certifications so that they can get paid, just to utilize the existing structure.
Mm-hmm.
But I think the actual, like what they are doing would be very, very similar across, because the problems are, the broad problems, the underlying problems are almost identical no matter which thing you pick. And then of course there are some specifics, but a lot of it is the exact same issues. I did want to add one thing from before, which was that the other problem that we haven't named that is related to all of this, the penalties, right? So if you're late to a medical visit, or God forbid you don't show up, and you do that however many times, depending on the clinic or the hospital system, you may not get another opportunity to see that provider again, or you may incur a fee. So that is another really problematic area where people who are already marginalized get further penalized for things that are out of their control, even when it's hospital provided. So I've worked with a lot of patients where they are dependent on some sort of car service to come and get them, and then that service gets behind because the 8 o'clock a.m. person was a little late and they waited, etc. And so now they're really late or missed their appointment. The medical system does not care what the reason was. It just knows you missed your appointment or you were late for your appointment, and now either you're paying money or you have lost your opportunity for care in this context. So that is another issue that I don't know what it would look like to address, but that was coming up as well.
So to that point, then, if there's good partnerships with primary care and there's a community health worker or a group of them at a primary care clinic, then if this community health worker is communicating that in real time to the PCP that, you know, they're stuck in traffic, or then it might be like a social worker stepping in to help someone in crisis. There might be a way, a mediator role, not mediator role, but a just like a great nurse on the telephone can fix almost any problem in the world. So, you know, a great community health worker on the telephone can sort things out and kind of keep the clinic moving and have that communication. So I haven't seen a lot of CHWs embedded in primary care clinics, but as a family doctor, to me, this seems like an essential component, especially for patients with chronic, anyone over 55 probably has at least one chronic medical condition, and then they stack up. And then if there's also substance use issues and relapse risk, if patients miss their appointments, I mean, it will more than pay for itself, but in terms of just human benefit, it seems like a no-brainer. Do you think the primary care community is adapting to this model, Rachel, based on what you've seen? I put you on the spot. Yeah.
Sharon, if I could jump in.
Please, yeah.
I to that question, that was a great question, Rachel. And I feel I know there are a lot of clinics, a lot of medical services that are doing full service. And full service means they take care of the whole person. And that is very helpful because that will help someone, that might help to answer some of the questions that Rachel was talking about. Why is the person not making the appointments? Is there something that the patient, that's why navigators might be key. Is there something that the patient is feeling about apprehension about going to this appointment? that maybe we can talk about, or maybe we can find out if that, you know, before we go through the process, because understanding that making an appointment is also or your schedule on the physician's schedule. So we want to make sure that they schedule stay in line, but also the patients may have all type of feelings. But when we have clinics that do round care, do that full service, helping the person in their spiritual and mental, but financial, making sure that all of the, I mean, we can't make sure everything is done, but at least address them. At least let the patient, let the client know that we're thinking about them more than just that 15 minutes. So yeah, I think that might help.
Yeah.
No, to answer your question, I guess what I would say is that I don't think that the structure of healthcare systems are set up to adapt. They're just not designed for adaptability, and then that limits what the providers can do. Because I was struggling, I was like, well, it's yes and no, right? I know a lot of primary, especially family medicine doctors who are like, yeah, they want to work with patients, they get it, like but they are still bound within the constraints of this very rigid system that is primarily answering to payer concerns. And so it's like, there's only so much even the best provider can do within that context, managing the schedule and, you know, all the things. So that's where there's some tension there. But I think there's an openness on the clinician side. Yeah, we want our patients to be well. We want to meet them where they are. But how do we do that in the system?
Thank you. And I think this kind of is a segue to the next question, which is how we implement results to what kind of policy change do we need to make that possible structurally, so that there was a National Academy of Medicine report on providing high quality primary care. They made a lot of recommendations recently for payers. But, you know, do we need CMS? Do we need the Blue Cross Blue Shield and others to maybe do some pilot testing or something so that they can begin to show the value here? What kind of policies do we need? This is the $1 trillion question to advance this model, because clearly, Karyn.
So I'm sorry, Rachel and Elliot, to kind of interject. So please feel free to say anything you'd like. I think one of the real issues that we need to contend with is obviously the systemic issue. In a model in which everything is funded by for-profit kind of model, we need to take a step back and look at how do we, you know, make it so that this for-profit model is really thinking about equity. And I think we're kind of on the right step to do that, but there's a lot more work that needs to go into it. You know, it's, you know, I feel for all of the providers who only have 15 minutes to work with a patient, right? I know when I do peer services, trying to get anything done in 15 minutes is nearly impossible. So I don't know how all of you are doing it. And I think we need to build the equity piece into it. You know, I think we're trying really hard, especially in the state of Illinois, to do that. You know, on the mental health side, the state of Illinois has put a lot of resources into making peer professionals, right? And getting paid for it and adapting to that. And we need to have more structures like that. Also, we really need to really build on the community health side, the community clinics that really do a lot of the groundwork, right? A lot of the work that we're currently doing is trying to keep people out of the emergency departments, right? Which a lot of people go to simply because they wait until the issue is so bad that they need critical emergency care. But equity-wise and change-wise, I think we need to focus on how do we create more models that are community-based, that allow practitioners to have more time and to really get to know their patients, right? Because emergency doctors just don't have that time. And that's not what they're there for. They're really there to handle, you know, cardiac arrest and, you know, serious respiratory issues. They're not really there to treat everyday kind of symptoms. And I think we really need to focus on how to create community models where practitioners really do get the time and really do get to know their patients on a level that's more than just a 15-minute in and out visit. So thank you, Rachel and Elliot, for letting me steal a little bit of your time.
Not at all. Not stealing time at all. That's a great. So the structures, yeah. that we need. It sounds like Illinois has invested in some of these structures better than other places, but I think the primary care academic community in spirit embraces this idea, but how to translate that into policies where it changes standards of care and practice models is a big question I have, and maybe a grand challenge for primary care. So the next question has to do with how to implement results from this work to translational science. And this is, Patrick, your, I guess, this definition of translational science from kind of bench to bedside, or I wonder if there's a broader spectrum than that this is maybe cell to society translational science, and how do we better measure, better design studies based on what you all have learned from decades of CVPR, and are we looking through the right lenses, and what's the challenge to translational science to do this even better in the next generation?
So I'm going to come out by disclosing I'm a psychologist. So I've studied a little bit about the brain and a little bit about neurons, but that's not my thing. I'm a community psychologist. So we've adapted CVPR for that area. It would seem to me if there's a neuroscientist who was on here and wanted to better understand the relationship between a certain neurotract and a certain set of symptoms, could CVPR have a role here? I'm not sure. I guess it's the degree to which the questions are so esoteric that they're sort of out of bounds of the normal experience our CVPR partners have. Yeah.
Well, I can say I've done some neuroscience work in my career, and that there has been a lot of research on the amygdala and what happens after the experience of violence or witnessing violence. Over time, it does change the brain, and that there's plenty of evidence that there is some neuropathology that results from early life stress and traumas across the board. And so are we also dealing with PTSD issues as part of this, and knowing that and how this might affect risk for many different behavioral things, including violence, does that change how we approach thoughtfully working with patients who, in addition to serious mental illness, may also have PTSD and other things that are triggers that can make it challenging. So maybe that's a big arc from.
I guess for me, Sean, could you do CVPR on this amygdala thing? I stayed awake in class. I know what that is. Can you do CVPR on this amygdala thing to come up with some better understanding? The minute to me you start talking about PTSD and symptoms and functioning, to me it seems you're away from the bench. And so at that point, to me, I would think people lived experience. They have this experience, it's lived. And again, I'm really struggling here, but I know my amygdala is working right now, but I don't have any lived experience of it. I don't know what I could do to sit with you at the bench to come up with a protocol to do better amygdala research.
Well, maybe the need is not to. I mean, we know that if someone's being chased by a tiger, their amygdala lights up red hot on imaging. But knowing that people may feel like they get chased by a tiger all the time just to get through their workday or through their neighborhood or this kind of thing, having empathy and understanding of that might help us design better ways to approach communities where we need to be cognizant of the fact that we're maybe dealing with people who've had a lot of trauma, and we don't want to add to that. I guess that's my converse of the question. Yeah, Karyn?
So this is a topic I'm very interested in, and I will also out myself. I'm almost a social worker. One of the things that we talk a lot about is post-traumatic stress, and especially dealing with communities on the south side and west sides of Chicago. And one of the things that we constantly talk about is post-traumatic, and one of the things that I think is super important is trauma-informed care and trauma-informed understanding, but also realizing that people are living with trauma on a daily basis. It's not post, right? It's daily. And figuring out that piece is very critical. And I think one of the things that we maybe for our next talk should talk about is how do we, in this model and community informed and equity and DEI work in a space where most of the people that we engage in the CBPR process are dealing with trauma and dealing with things on a daily basis that, it's hard to get up in the morning. I work with clients who have had 2 or 3 children murdered because of gun violence. I work in communities where, there is a very serious concern about being deported, being taken away from their family, and how do we incorporate that in this process? And I think that's super important. I think that's one of the things that we're continually trying to figure out how to do, and we're all doing the best that we can, but that's one of the things that I think is super important, that we need to kind of shift that focus. Is most people that we're working with in this space, it's not post anything, it's a continual daily thing, and how do we really address that? So thank you.
Thank you. That was a wonderful comment. And I'd say a very translational one, because we're talking about what we've learned about the brain, but awareness of that and how that affects the patient experience. So very good. So can we go to the next slide, Rachel? And I wonder if we could put up that flyer again too. We're at the end of our time, but I wanted to thank the speakers and the panelists for a really outstanding presentation. I feel like I've learned a lot by listening and challenged to do better in primary care, to work more with peer experts. I think that what we've seen today is quite a bit of evidence that this peer support model improves outcomes, improves a number of processes, and that we have a long way to go in our systems to get where we need to be. So we need to keep talking and about solutions. So thank you all very much. And so just for follow-up, there's a flyer with information about the junior investigator training and the pilot funding. If participants, we don't have a link to this on the web, but if they contact me or Rachel, we can send this out to you directly. But it's a really great opportunity for all of us to learn more about CBPR, but also a funding opportunity for our junior investigators. So this is really great, great resource. Thank you very much. And then just if we can just kind of go on to back to the slide, Rachel. Feel free to contact me with any questions, comments, concerns. There's an evaluation. I think, Rachel, you're going to put that link in the chat box for the evaluation right there. And then, so we would love to hear from you. We're also going to send out a link to the evaluation and to the YouTube video of today's seminar. And of course, there's the CME credit aspect as well. So, so Karyn, Elliot, Rachel, Pat, and Rachel Brewington, thank you so much for today, and happy holidays.
Thank you. Have a wonderful holiday season. Bye-bye.
Thank you. Thank you, Sean. Thank you, Rachel.
Thank you.
Bye,
Rachel.
everybody.
Bye.
Have a good day.